start the show. I looked outside, I didn't see anyone else coming from the parking lot, so.
Good evening, everyone, and thank you for all coming out to be part of this hearing. This is a hearing that we've been trying to have since November, and I thank you for it finally to happen. I want to give you a little bit of background as to why we are here tonight. And in November, I happened to come across an article about what was happening in our town of Bennington, that our paper didn't have anything about it. No one knew anything about it. I went to our town manager, Stuart Hurd. He didn't hear about it. Fellow legislators hadn't heard anything about it. And so I reached out to the good folks from our Agency of Human Services, and I will introduce the staff here after I make my comments. My concerns at the time were hearing that the former, or I'm not sure if it's gone through yet, and I'm sure we'll hear tonight whether it has, because the date kept getting pushed back and answers or questions were not being answered quite the way they should have been. My concern with the proposal was that the Bennington Health and Rehab originally had, I believe it was a 94-bed placement. They were downsized to, I believe it's 42 or 44 because of staffing issues, and they were not being able to provide the care that was needed for a nursing home setting. So fast forward, as I'm reading this article, they are now proposing, iCare is proposing, to put 3 very challenged populations into the nursing home with the patients that are still there. That would be a nursing home type of patient that is usually fairly frail and or has a disability. The populations that they are planning to bring to the facility, and I'm using their words, I'm using what was in the original first story that I read, folks with extremely complex issues, from folks being addicted, those with serious mental health issues, and also folks coming in from corrections. Again, in a given situation and setting, it may not be the best thing for those populations to all be intermixed, but I'm not the expert here. When I asked those questions in regards to how is this going to work and would you have the staffing, the answer was always that's a good question. Well, to me, that means you don't have an answer, and I'm not trying to put you folks on but that was our original first discussions were not pleasant. That's why I wanted more information, and for these citizens who were then asking questions to get the answers. We all understand in this room, we're a good community, we care about people, but you've got to understand all of the populations, including the most challenged that we're presently talking about, need to be housed and housed somewhere safely, not necessarily in this intermingle of, well, we might have this because we don't know if it's gone through yet, and probably the ink is dried on the paper as we speak. but we need to have an understanding how this works, and especially in a neighborhood that is very close to the building. You know, when I asked Stephen about, and I sit on the Institutions and Corrections Committee in Montpelier, and we deal with a lot of the issues of placement and folks, you know, where safely they can be taken care of. This isn't about being against a population or their needs, but you need to do it sensibly, and you need to do it where you've got qualified folks and staff that can deal with the various populations. You know, otherwise I would think it could be a challenge. When I asked the commissioner, because again, using what was said in the newspaper article, was that our interim commissioner enthusiastically endorses this plan and this proposal. And yet when I asked, have you been to their facility to see how it actually works? And the answer was no. That's concerning to me, very concerning. So this meeting is about all of you, and I hope you will take the time to stand and ask your questions. I know there's a lot of you. I'm hoping that, you know, you will ask a question, possibly sit down to let someone else, and you will get an answer, I believe, from these good folks, and just so that everyone has an opportunity who would like to speak. I think I will leave it at that at the moment. I may have a comment later, but again, this isn't about me, it's about all of you and what's being proposed. So at this point, I will introduce the folks who are with us this evening from the Agency of Human Services, and that is our interim commissioner of Dale, which means disabilities, aging, and independent living. And that is Megan Tierney Ward, the second person in. And with her is Rebecca Silbernagel. I hope I didn't quite murder that, and she is the principal assistant to the commissioner. Also, I had wished that the new commissioner, there is a commissioner that was just appointed by the governor. Her name is Dr. Jill Brown, but she will not be on deck until the end of April. I had wished that she could be here because she's the one, if this goes forward, that's going to have to deal with all of this. So, and then from iCare is the Vice President of Business Development and Communications, David Skozlek. Okay. And with him is Jess DeRing, and she is the Operations Director for Mission Care Health. iCare is, I believe, the overall, what is the term I want? The overall person that runs all these different facilities. But if this goes through, the building here would be under Mission Care. So there's a couple of names floating around, but please feel free to come up when the time is. How are we? Should we do it by hand? And we.
Yeah, I would think they should be recognized.
Okay.
And direct their questions to the folks.
Right, absolutely. So does anyone have a question or a concern or a statement they want to make?
Yeah, let's have the presentation.
Oh, excuse me, that is correct. Forgive me, it's been a little busy. iCare and I believe the Agency of Dale is going to do a PowerPoint for you to see what they're all about, and then after we will have the questions. Thank you.
Great. Thank you, Representative Morrissey, and thank you all. What an amazing turnout. I have to admit, I'm a little nervous because I'm really excited to hear what, yes, okay, good test here. How's that? Good? All right. So thank you for turning out, for coming. for coming to listen, for coming to ask and pose the difficult questions that hopefully we can answer for you today. The PowerPoint presentation contains a lot of information. We will try to keep that tight and crisp so that we have plenty of time for you to come up and ask the questions that you need. I'm going to give a little bit of an overview, so just sharing with you the process to date, leaving the details to Dave and Jess. So again, my name is Megan Tierney Ward. I am the interim commissioner, and Dr. Jill Bowen will be joining us on April 22nd. So I'm really excited to have her in our team and to carry on the work that we're doing. With regards to an overview, because I wasn't sure who was going to be here in the audience and who understood the background of a nursing home even, I thought I would just start there. So nursing facilities are federally regulated and provide a level of care that raises up to what we call nursing home level of care. So those are folks who need nursing, who need personal care on a daily basis, and they have a medical condition or a disability which makes them need that level of care. In Vermont and across the country, the Centers for Medicare and Medicaid Services regulates that care across the state, the same way in every facility. In Vermont, we also have a Medicaid program that covers care in all settings. You might be familiar with something called Choices for Care, and that's the name of the program, but it's the way that people come in and get that level of service in different settings, including nursing homes. So in Vermont, we have 36 nursing homes, and we noticed that during the pandemic primarily, because you might recall that it was really tough in nursing homes. People were not being served. We had a very low occupation or low census around the state, meaning it was about 70% of the beds being full. And we also noticed that a lot of folks were getting stuck in hospitals around the state. So that was kind of a different reason because COVID had its own problems. But we realized that the difficulty of care had more to do with those things that come together with the medical care. So you're there in a nursing home, you have to need that level of care first of all. And then certain folks who also had a combination of other diagnoses like a mental illness, maybe it's dementia with behaviors as well. We're having a really hard time finding a nursing home in the state under our traditional model of care. So at the point in time where we realized that we had folks who had some more challenging care needs, could not be met in a traditional nursing home setting, in a typical setting, we realized we had to do something about it because the state was paying for people to sit in hospitals. We also have folks who are in the justice system, so they are in jail, but when they finish their sentence, there are some people who have grown old and also have either a medical condition or a disability where they need nursing home level of care. And most of the time, those folks have no, I'm calling them behaviors, but any concerns related to behaviors, but they have a history, right? So that makes it really hard to find a place that will serve them. So we have those folks who we're calling complex care. And in 2022, we were still a part of the pandemic. We decided that we would do a request for information and then a request for proposals, and that's the state procurement process when you look for someone to do a certain type of work. And we did that in September of 2022. And iCare Health Network applied for the request for proposal and won the bid to create a model of nursing home care that was able to meet the needs of more complex care folks. At that point in time, and of course this changes day to day, but I think we're still at about that number. At that point in time, there were about 100 Vermonters in the state who had that level of care need. And so in the overview, we talk about that process, but what's really important to know is that at that point in time, this work could only happen by partnering with the Department of Disabilities, Aging and Independent Living, DALE, my department, together with the Department of Corrections and Department of Mental Health. So we worked to put that RFP together, and since that time, when the RFP was issued, we've created a process where we did a Phase 1 contract, and now we're in the midst of finalizing a Phase 2 contract. The Phase 1 contract allowed iCare to come into Vermont and be able to do their search. There was no nursing home identified during that RFP process. So the whole process that iCare brought with them to the table was a process to identify the ideal place for to buy, for iCare to purchase, and to create this licensed nursing home with this specialized care. So where we are right now, Representative Morrissey is correct in that we've had a couple of fits and starts on our timetable, and right now we're still finalizing the contract language for the Bennington Health and Rehab arrangement with iCare so that they could do the closing on the property, and then that would allow them to actually start providing the services. So we're in that final stage now, and there's an anticipated, actually maybe I'll let you decide, you talk about kind of the rollout and the details around the sale of the nursing facility. I'm going to stop there, and for those who do have a copy of the PowerPoint, I want to point out also the overarching goals. These are goals that we identified. It's on the first page, second slide, and that are really important to our department, important to the project, important to Vermonters that we serve there. And it's just important to me that you know that the missions of our department, the missions of the Department of Mental Health, of the Agency of Human Services, but also to make sure that we have this high quality care. And I know there's concerns about that, and we'll try to answer those questions when we go through the details. But also to reduce the number of people stuck in hospitals, to reduce the number of people who are stuck in places that are inappropriate for them, and be able to get that care in the appropriate nursing home setting in a safe and secure way that meets their needs. So I hope that you see that after today's presentation, and again, please come up and ask all the questions you need to make that happen. For folks who did not get a copy of the PowerPoint, perhaps we can be sure to get some more copies made at the town so folks can have that in their hands if you'd like. So I'm going to pass this off to Dave to continue.
All right, thank you, Commissioner. Can everyone hear me? Is this close enough? How about this? Better? All right. So thank you for that. Thanks for everyone for being here. Happy Easter if you celebrate. Thanks to Representative Morrissey for helping put this together. And my name is Dave Skozik. I'm the Vice President of Business Development and Communications for iCare Health Network. It is like a long slide deck, as you see, if you got a copy of it. So I'm gonna stay on task. I'm gonna get through it fairly quickly. No digressions, no stories. Just stick to what's here, and leave plenty of time for questions. But what I did do is I put the large numbers of the slides up on there and on your slide deck, so that if you want to say, let's return back to slide 7 and where you said, and that way we can go back and reference that when I finish up. But like I said, I'm going to try to move along, try not to go too fast, but cover all the details, and we'll get through it. Yeah, please.
So I'm just going to interject for a minute. I'm Jess Doring, so I'm the Director of Operations for iCare for Mission Care Health, which sounds very official. I'm just going to give you my history real quick. I am a nursing home administrator. I've run nursing homes for 26 years. I know it's a shock. I'm not that old. But I'm going to tell you that there's a threat that I will digress and I will tell the story. So I'll try to stay on. This is my first meeting. But thank you for having us.
There we go, it's back on. All right, so there's just a couple things we'll talk about just to lay, a groundwork on who we are. So iCare Health Network we are Connecticut-based. We're in a suburb of Hartford called Manchester. All we do is operate nursing homes. That's our business. So we have 10 nursing homes in Connecticut. We have one in Western Massachusetts, and we have the incumbent one here in Vermont. So you can see that's the name we use for the entire company. They have our individually named care centers, and then we have a number of different companies that we operate in addition to that, just that provide care inside the center. So iCare is, again, that's the operating company for all of our facilities. We have a couple of different brand names under that, but Mission Care Health is the name for the line of business that cares for this special population. So that's why it would be Mission Care at Bennington. So we have about 1,400 residents that we care for now in those sites, about 2,500 employees. I mentioned that 11 location with Vermont as the 12th, and then actually today, April 1st, is our 25th anniversary in operation as of this morning. So we've been around a while. Nursing home companies don't tend to have that kind of longevity. They get bought up and changed hands and all that kind of thing. Not for us. We've been around 25 years and very slow growth, and everything that we do is kind of gradual and thoughtful. Except for, there we go. So under the Mission Care Health name is 2 centers now that exist and have for some time, and then Bennington being the third. When we started it, we started 60 West, which was the first nursing home of its kind in the country. The name is it's 60 West Street in Rocky Hill, so it's a very generic name, and at some point we'll probably go back and change it to Mission Care at 60 West or Mission Care at Rocky Hill, but it's the same as the other two centers. So that one, we just passed our 10th anniversary. That was last April, right? Yep. Yeah, so we're just about 11 years in operation of 60 West. Same exact model. Everything that we describe here is the same between there, Holyoke, and Bennington. In 2021, actually prior to that, we started to consult in Massachusetts at a place called Farron Care Center, not too far from here. And the state of Massachusetts had seen what we were doing in Connecticut, asked us to replicate it in Massachusetts. We had located this facility in Holyoke, which is a very, very nice physical plant up on the hill. It used to be called Mount St. Vincent's, and I'm going to kind of return to that project because it's very similar to what we're doing here in Vermont in almost every way. So I have a couple things that kind of tie into that. So those are the 2 centers that we operate now specifically in this model. So when the request for proposal that the commissioner mentioned was put out, we had to answer a long series of questions, describe who we are, how we have any kind of specialization in this or a skill set that goes towards managing this population. So here's basically what we do at all of our centers across Connecticut, Massachusetts. We have 8 secure behavioral health units. A behavioral health unit in a nursing home means that somebody's disabled by virtue of a behavioral health diagnosis, like they might have schizophrenia or major depressive disorder, but they're not acutely behavioral. If they have acute symptoms, if they're acting out, if they need their medications managed, if they need sort of more aggressive management, they need intense care, that happens in the hospital or it happens at Brattleboro Retreat or a location like that. A behavioral health center unit in a nursing home, again, just means that they have a diagnosis where they need to have extra supports. We have training for our staff. They have, we might have consulting psychiatrists that come in to manage medications, but they're not there for an acute psychiatric incident. Just want to make sure that's clear. So we have 8 secure behavioral health programs across our centers. We have 7 secure memory care units. We have a Huntington's disease program. We have 1 of 2 HIV programs in the state of Connecticut inside skilled nursing. We have a veterans program. We do substance use disorder through a program called iRecovery, where we care for folks that have substance use disorder, but they're still in the nursing home for a nursing home need. So they come to us because they need therapy or they need nursing, but they have a background that includes addiction. I'll talk a little bit more about that at a different time. That's a program that we run extensively in Connecticut, but it does not really cross over into these types of programs. It does in a very narrow way, and I'll mention that a couple more slides from now. We have advanced heart failure programs. We have, a lot of awards that we've won from the American Healthcare Association Quality Awards, Silver Awards, and then we have a number of facilities that have won U.S. News and World Report Best Nursing Home Awards, including 60 West was one of those. So again, this is kind of the same thing. It just shows you what our bed counts are in those areas. So we have 300 behavioral beds, 350 dementia beds, 150 doing substance use disorder. Connecticut's program, similar to this, is 95 beds, has been full for a while. Massachusetts, 125 beds, also full for a while. And then we do standard short-term rehab and long-term care as well. So we have what we would call 600 traditional nursing homes as well. Our model is to turn around distressed assets. So we've bought nursing homes out of bankruptcy. We've bought them when they've been in financial distress or they've had issues with care. And we come in and we fix the care, we fix the financial model. It's not always that way. Some of them are very much in that model, and some of them are just, like Bennington is not in that category, but has some care issues that we will certainly address when we take over the operation. So what are the services that we'll provide? And these, I did put pictures in here. There's every picture that you see was done by a professional photographer, but they're not stock photos. These are actual photos from these two specific care centers. So this is one of the residents from 60 West who's gardening. Unfortunately, just passed away. Very sweet guy, passed away a couple months ago, a month or two ago. And then that's a semi-private room inside of 60 West there. Hold on 1 second. I think it stopped working on me. Yeah. There we go. Yeah. Sorry about that. All right, so this is a list of service and clinical capabilities. This is what we'll be providing inside of Mission Care of Bennington. The short version is this is a list of what every nursing home provides inside of a nursing home, and that's what we'll be doing. 24-hour care, assistance with activities of daily living, physician services, et cetera. You can see the whole list there. Again, that's pretty classic nursing home capabilities and services that we provide. Again, not stock photos. This is a gentleman who's a resident at 60 West there on the left-hand side, and a recreation working with a group on the right-hand side. So one of the things that we continue to make sure we put a fine point on about this is a nursing home without any exceptions, without any waivers. There's no skill set, or there's no rules that say you're a nursing home except you can do this or except you can do that. We are a nursing home 100% without waiver or exception. That means we have to follow every federal rule. We have to follow every state rule. State inspectors come in on a regular basis and do a full survey of the facility. There's absolutely nothing that we're off the hook for. There's nothing that is changed for us. There's nothing we've applied to the state to have as a difference. And if anything, we tend to face more scrutiny when by virtue of what we're doing. So there's not a workaround for us. We follow all the guidelines that are issued by the state and the feds. So that means that every resident that's admitted to the facility must meet the federal guidelines for nursing home, full stop. So they're not nursing home residents, but they're all nursing home residents. They go through a third-party review for a system called PASSAR, which is an acronym. It's a company that's separate from us, hired by the state, required federally, that reviews every person who's admitted to any nursing home at any time and certifies that they are safe to be in a nursing home, that they meet the requirements for the level of care of a nursing home, and that their primary diagnosis is not mental health, and that they're not being warehoused there for the purpose of treating mental health disorder. So we still go through that entire process. Again, it's a third-party review. We have no say in it. They just issue their findings. And then I'll get into more detail about how we establish which residents we're going to admit. I know that's certainly a question that people have, but that is done by a committee that includes members from the state as well. So it's not iCare independently deciding one way or the other who's going to be admitted. There's sort of what we call a utilization management committee, just determining which beds go to which individuals. So again, individuals must meet all nursing home requirements. Everybody who lives here could live in any nursing home. Literally any nursing home in the country, anybody who resides here could do that. They'll meet all the requirements, as I said. It's just that no one's considering them. And their concern is that you bring in an individual with this kind of stigma, and then their roommate decides they're going to leave, and then the other people decide they're going to leave, and then it just puts a domino effect on the nursing home. and they don't feel that they're in a position and they're capable of caring for these residents. So that's where we come into these states, because we do have that skill set, and we can manage these folks, and we're really good at picking out which individuals we're going to admit. So we're just taking we're taking from the same pool of nursing homes, that are otherwise being considered. And we will see cases like in Massachusetts where the state will say, looks like a patient that should go to Mission Care at Holyoke, but we think maybe 4 other nursing homes we know of might consider them, and they send it back out to those nursing homes, and occasionally they do say yes, and then they come off of our list. But most of the time they say no, and it's back to becoming us that's caring for them. Again, 2 real residents of 60 West, kind of gives you an idea what these folks look like. So our referral sources, very straightforward. Acute care hospitals, Southwestern Vermont Medical Center, already been having extensive conversations with them. They certainly have these folks as well, not to the same scale as you might at a UVM or an academic medical center, but we're seeing them from across the state. We do get referrals from correctional institutions and their infirmaries, and we'll talk more about what that looks like. Mental health hospitals, I just had communication with Brattleboro Retreat today, and we're going to have another Zoom with them. We've been talking to them for over a year, so that's a referral source, and it kind of works both directions, because if one of our residents needs a higher level of care, then we'll have an arrangement with Brattleboro for that to be facilitated. Some of them, like Department of Mental Health residents, otherwise are in a community setting, such as a group home or congregate housing, sometimes private residence, sometimes a hotel. They're not doing well there. They belong in a nursing home. They're being followed by a caseworker. That caseworker says this person definitely needs to be in a nursing home. They need 24-hour supervision. They need 24-hour care. We see that as a referral source. And then miscellaneous, whether it's community case managers, population health, sometimes the ombudsman, state officials will have identified a case that they want us to consider. This is a picture I use on almost every presentation I ever give, because it's really a good demonstration of who we're talking about, that we're caring for. This is from our Christmas party at Mission Care at Holyoke from this Christmas. And this group, the larger group, is a mix of staff, residents from when the nursing home was a classic nursing home, a traditional nursing home, and residents that have come there since it became Mission Care, all caroling together. And so they live in the same setting together. It's just a good, visual representation of what we're talking about. So main resident categories, one of the ones so currently residing in a location that's not appropriate, like as the commissioner said, it's something that's more costly, more restrictive. They're at University of Vermont Medical Center. They're on a medical surgical floor. They've been there for 800 days. They absolutely belong in a nursing home. They're not really allowed to leave their room. There's no activities. There's no recreation. They're basically stuck in their room watching TV and getting meals in a setting that's not conducive to them, and also costs 3 or 4 times as much money for their care. They absolutely belong in a nursing home. It's been sent out dozens of times. Nobody's considered them. We look at them, we're like, this is a nursing home resident. They just have some factor that somebody doesn't want to consider them. That's a main category for us, and there's certainly patients all over Vermont that are in that category. There's also very well represented from our list of Vermont residents residing in out-of-state nursing homes due to no in-state nursing home considering them. So we know that a lot of these nursing homes, that we work with them in Massachusetts, that tends to be the most likely place for them to be. So they're in the Boston area, or they're in the Springfield or Worcester area. They're living in a nursing home. They have successfully been living in a nursing home because that's where they are now. They want to be, for the most part, back in Vermont. Their family wants them back in Vermont. They could be from the northern parts of Vermont, so their family can't get to see them on a regular basis. But those are, for us, are relatively easy straight line, because we can look at their nursing notes and see 6 months of them residing safely in a nursing home. Just happens to not be one in Vermont. Individuals who are residing in the community now, followed by DMH, I kind of mentioned that, Department of Mental Health following them, and just kind of sees that their mental health is not declining in the sense they're getting more behaviors. Their mental health is declining in the fact that they need more assistance with their activities of daily life, feeding themselves, clothing themselves, showering. And DMH is saying this is somebody who's going to be a nursing home level of care. They can't continue to live in the community. And then the one that obviously draws a lot of interest is individuals who are living in the justice system in the past or currently in the correctional system, typically living in an infirmary setting. They are capable of being released through compassionate release, end of sentence, end of life. They're older. it's, when we talk about the age, they could be 65 and be older, because if you've been living in corrections and you're 65, you generally have the body of a 95-year-old. So, age is not always as well correlated, but they're typically somebody who's served a long sentence. Their crime is from a long time ago. They're very cognitively declined. They're very physically declined. The infirmary, when we go to see them in this setting, they're just laying in bed. They are only able to get up with the assistance of others, and they just don't really belong in a correctional environment anymore. And a lot of times they're just at their end of the sentence, and the corrections is saying they're just going to be released to an ER, or they're going to be released to the public. They're going to be trying to find housing. They're going to be living in a shelter, but they meet the requirements of a nursing home, and we consider them. Did you have something? No. Okay. All right. So, and I have a couple more things on that, because obviously that's going to be of greatest interest. And then others who have a behavioral diagnosis or some other stigma, we get some kind of miscellaneous ones that sometimes people get in this situation where enough nursing homes have said no, that when the referral goes out again, they're like, there's some reason this person's been sitting in the hospital for 300 days, I'm not going to look at them. And so it becomes less and less likely over time that they will get considered by other nursing homes. So more importantly, or just as important, is who will we not be considering for admission? Who will we not be caring for here? Anybody who's an individual in unstable behavior or any other factor that shows they'll be unsafe or disruptive. So they can't be actively having behaviors. They can't be actively being assaultive. They can't be verbally aggressive. They can't be in a situation where they're not stable. If we're reviewing them and they're still changing day to day, or they just don't look like they fit in a nursing home environment, they won't be considered. It has to be somebody who has demonstrated stability. Anybody who does not have a risk mitigating factor. So these two things go together. If you're living in a nursing home, you're generally going to have a risk mitigating factor anyway, because something has to make you a nursing home patient. So cognitively declined, physically declined, there has to be some reason you have to be in a nursing home, as I mentioned, and that also works towards the fact that it mitigates your risk. Again, picture a nursing home patient. They're not somebody who has the cognitive ability generally, or the physical ability, not always together, one of the two, that limited capacity on their part limits their risk as an individual living in a nursing home. So if they didn't have any of those, if they're fully cognitively intact and they're fully physically intact, they don't belong in a nursing home in any situation. If they've had ongoing negative interactions with staff and peers, anywhere they're coming from, we have notes. We either have pages and pages of clinical notes from the hospital, we have them from the other nursing home, we have them from their case manager. We'll review every bit of those notes to see what their interaction is with their peers, with their roommate or whoever they're in with the staff. We just pour through all of that to make sure they're not having negative interactions with folks. Sure, they do come up. You can guess that that's like a range, having some kind of back and forth with your roommate's not the same as swinging at somebody or having some kind of major outburst or a pattern of negative interactions. No one will live here who doesn't want to live here, so regardless of where they're coming from, obviously if they're not their own person and they can't make their own decisions, that's a little different. But if we have somebody who's adamant they do not want to live in a nursing home, or they do not want to live in this nursing home, or they don't want to live in Bennington, or they want to be closer to home, they have to want to live where we're caring for them. We do not and will not at any point rehab people to send them back into corrections or into a correctional environment. So when we talk to other states, usually in other parts of the country, they'll say, well, we're looking at a program where you would care for people that needed physical rehab and nursing care so they can come back and finish their sentence. And we're like, that's not what we do. That's a different mission. We're not interested in that. For the piece of this that is related to corrections, these are people that are free and clear of the corrections environment. They've been paroled, or they're on probation, or they're just completely into sentence where it's like, they're free to leave. And we're not doing anything in order to increase their capacity to go back and continue any kind of sentence. It's just, again, not what we do. And then any individual that's deemed high risk on evaluation. So I'll talk again about how we review people, but anybody who meets the level of high risk at any point is just, we might continue to follow them. We'll check in on them in 2 weeks or in 2 months, or we'll see what how their status changes. But if they're high risk in any way, they just won't come in. Again, more pictures from, you can see the staff and, inside the center. And top left was a wedding we actually had at 60 West for this gentleman who's crying just before he passed away as one of the residents. So some operational details. Residents, there's a little bit of confusion, I think Jim from the Bennington Banner did a great job with that article, but there was some things that I wanted to kind of clarify. Residents will be placed based on their diagnosis. I think it's a bad connotation to say, if you're coming from this referral source, we're putting you up here. If you're from this referral source, we're putting you in this unit. That implies that we have to be concerned about their custody. This is not a custody, they're here for care. So they get placed based on their diagnosis. If they have overwhelming dementia and they can't do anything for themselves, they get placed in the memory care unit where they're going to receive memory care supports. If they have schizophrenia and they can't toilet and they can't get dressed, and they're going to be on a secure behavioral health unit. That's how they'll be placed. Residents will not be walking outside of the center or in the neighborhoods or out on out trips or riding around in vans or at any point. They'll be doing recreation and doing activities inside the center. If they have to go out for an off-site medical appointment, they'll be accompanied by staff at all times. Again, I think it's really important to know you will not see residents walking in the neighborhood. Some congregate living or adult housing and all that stuff will have, those residents do. This is not how that works in a nursing home. They receive all their care inside the center. The center has 24/7 staff at reception. Of course, it has 24/7 staff throughout the building, but many nursing homes do not have 24/7 staff at the front doing access control and doing all that, side of things. All of our centers that do this have 24/7 staff at the front desk, in addition to, throughout the building, obviously. And then it was mentioned also in the article, I want to clarify that we use what's called like a Wander Guard system. That's like a name for, the company name for it, but basically it's a bracelet that detects if you're leaving the threshold of the unit that you're on when you're not supposed to. So if they're living in a secure unit inside of a nursing home, means key-padded doors, and it means Wander Guard system. So every resident has that on. Can't take it off. It's snapped into place, and if they left the threshold of the unit they're on, it would set off the alarm. So that's how access is controlled. And then like I mentioned, we've had conversations with Southwestern Vermont and with Brattleboro Retreat, so that if somebody is decompensating, medically, they'll obviously go to the ER. If they have some psychiatric decompensation where they need their medications adjusted or something like that, and they need to have an acute stay, we'll have an arrangement, or have spoken with Brattleboro Retreat on having Rescue Inc. come and have them transported so they can receive acute care. My point being that we won't be taxing the local ER with residents, and I'll talk a little bit more about that, but that's part of why we have that set up this way. It likes to seize up on me. A couple more slides. Yeah.
Knowledge is power, so we're trying to get it all in, so you'll have it.
Sorry, I'll keep moving along.
One of the things, just to touch on for David, the Wander Guard piece for people with access control is that because if they were out in the community would be a risk to them, not because they're a risk to the community. I hope that makes sense.
It likes to freeze up on me. Which slide are we on here? All right, so let's give this a second. You can see the connections paused. So I'm on slide 22 now. So slide 22 is about how we review potential residents. So the biggest factor about this is, like in the rest of our nursing homes, we could see somebody, we could receive the referral at 10 o'clock in the morning, and we could be admitting them at 5 o'clock at night the same day. That's not what happens here. This is usually at the fastest I think I've ever seen it outside of somebody's actively dying is probably 2 or 3 weeks. But our typical time from the time we receive a referral to someone admits to us is probably closer to 6 months. That's because we do that complete review of their records, and then we also see everybody in person, interview them in person. So there's an extensive process, and our principal way of controlling the risk is time. So if we see that somebody needs more time and more notes, and we need to see more nursing notes, we need to see them in person again, that's what we do. We use a seasoned nurse to see these patients. That it's the same nurse that does this for our centers that do this kind of service. So it's not 10 of my staff or 20 different people seeing them. It's one person who specializes in this type of population and knows what she's looking for. I mentioned that she does on-site in-person evaluations and interviews. I mentioned the long time frame, thorough review of all the records. I mentioned the committee of the state experts to consult with us on who's appropriate. And the idea is to know everything you need to know about these residents before you make a decision and long before they come into the center. We should not be discovering anything after they arrive. So we've gotten really good at that. More pictures of staff. I'm not going to read all these, to Representative Morrissey's point, where I want to keep moving along, but this is what we found to be keys to success in this population. So it's just details on the extensive training and policies and procedures and all the things we've kind of set up in the last 13 years of doing this, including our own training for the staff on crisis de-escalation and avoiding crisis in the first place, how we manage the access controls and whatnot from there. Again, more project specializations. We will want all of our own staff. It's important to get the right staff in the door. So, when we talk about staffing limitations and challenges, that generally means, it does not mean you're supposed to have 20 people working and you have 15. It means you have 20 people working, but 5 of them come from a staffing agency, and that's not ideal. You want to have your own long-term, directly employed staff. So when we come in, there will be agency use like there is in the center now. It's actually very extensive agency use in the center now. And one of our goals will be to fully change that over to our own directly employed staff. Again, I'm not going to go through all the bullet points here just for the sake of time, but these are all the things that we've found help to make us successful. I'm just making sure there's none that I don't want to put a finer point on here, but you can see those there. What's that? Yeah. So some of the concerns, Representative Morrissey and I had some very extensive phone calls, as she mentioned. There's a concern about insufficient nursing homes in the area. There's a lot that can be said about that. I mean, the center was running in the 40s out of 93 beds. That's not really sustainable as a business model, as you'd guess. You can reduce the size of your staff and stop using some of the units. But the smaller the nursing home gets, the less efficient you are, all the way down till you're so inefficient you can't stay open. So that's not a level that they would want to have run at for any length of time. When we see that, to me, that means there's not enough referrals out there to fill those beds. So yes, they probably needed 45 beds. They didn't need 93 beds necessarily. And what we were seeing is, the current operators, great, we've been in close contact with them, but you tend to end up bringing residents in from further away that are more challenging for them to manage. So they start taking in kind of the same residents we're anticipating to care for, but without all of the supports that I've mentioned and all the infrastructure and everything. So they've had their own staffing problems, their own quality, some quality of care issues to speak of, and those are the things we're going to directly address as soon as we take over the operation. In terms of mixing the populations, there's a lot to be said there where we're going to have extensive conversations with the families and the residents that are there now. That's a whole different meeting than this. That's repeat hours-long resident council meetings until we answer every single one of their questions about what's going to happen with their loved one and what their decision-making process is. I think you saw in the news, nobody's going to be asked to leave, made to transfer. That's all going to be up to them as to whether they decide to do that, and we'll help in any way possible. I've made that personal assurance that I personally will help with any relocations and any transfers. We know that's not ideal, but in the Holyoke version of this, and why it's so similar is when we bought Mount St. Vincent's, which is now Mission Care at Holyoke, they had dwindled the same situation. They could not get the census up. They had dwindled down to 52 residents. They were not financially viable, and essentially Trinity Health in New England's Mercy Senior Community, who owned it, said, if you guys can take this over and move that population from Turner's Falls and put the two together, you should be able to make it function. But if you don't buy it, we're closing it. So we did buy it. We did all the resident council meetings with all the family members and everything else, and we only one family left. So all of the rest of those residents, all of their families, they all stayed in place. They're all there. A lot have passed away because that's what happens in a nursing home over the course of a number of years because it's an older group. But we only had one that decided to leave. So we do have an experience with merging those two populations, and we will work our way through that with this population here. It may be different. They may be more folks that want to leave, and that may happen. Representative Morrissey had expressed a concern about finding staff. We know that that's a difficult thing anywhere. It's expressly difficult in Vermont. It's one of the top 3 states in the country that's a challenge for staffing nursing homes. We have a lot of experience with this. We have a cross-section of our team that includes all the way up to the CEO who meets weekly on recruiting. And we've gotten it down to a science enough in Connecticut and Mass anyway, where we've we're hiring 30, 35 people a week across of our buildings. We know this is going to be a challenge. You've probably already seen some of the ads. You've probably seen some of the stuff online. We're running it in the newspaper. We've had job fairs, but that's just scratching the surface of what we do to try and bring in staff. And again, not to staff from 15 to 20, but to displace those agency people that are there for our own long-term people. Utilization of public safety services, we've been in touch with Bennington Rescue, we've been in touch with Bennington PD. They were both very nice and we had great meetings. It tends to be that this nursing home uses less police response and emergency services than an average nursing home. And so if Bennington Health and Rehab were full, because we'll be full versus they're lower, and you compare the two, we would use police and EMS less. The reason for that is because it's our job to foresee issues and to start figuring out how we want to care for that resident earlier on, and so that if they are decompensating, it's not, we're not making a plan when it happens. We're bringing in our specialists to figure things out in advance and see if they need a different level of care or whatever they need in that regard. And because there's no short-term rehab, these will be all long-term care patients. So nursing homes are usually long-term care, short-term rehab, and then something else like memory care mixed in. 100% of these will be long-term care folks, so they tend to be much more stable medically, so there's a lot less use of EMS. And then we've been in touch with the emergency department. I talked to Tom D, and I talked to folks over at Southwestern Vermont. Inevitably, patients go to the ER, but it's been my assertion to them that we will make sure that we are not overusing their ED and that we have a plan for everybody and that we're in tight communication. This is our letter from Rocky Hill PD saying the same thing. Rocky Hill Police Department saying to us, we go to your nursing home a lot less than we go to every other nursing home in town. So we have had experience with the police saying they're just not there as much. Very busy slide. I'm going to, for the sake of time, skip over this, but every 2 weeks after somebody's admitted, I send the referral source a update on how they're doing, and I boxed a few of these out, so when you get a chance, and we'll make sure there's additional copies. But you can kind of get a flavor for what these residents look like based off of what their review, what their 2-week updates look like. So just one of them I'll read. DF has adjusted well to his placement at Mission Care at Holyoke. He speaks minimally and is a total assist for care in all areas. His healthcare proxy hopes to visit him in the near future for the holidays. He's eating well and there are no behavior issues to report at this time. So again, classic nursing home resident, but these are, obviously my samples, but these are direct cut and paste from the emails I sent. We do have the sake of time, again, our staffing plan, besides what I just said, was not only to do all of those things for recruiting, but with the state, we've described a fill-up plan that is very conservative. So 3 to 6 residents per month would admit. So we're not talking about a bus coming in on day 1 or week 1 or month 1. 3 to 6 new residents per month. If you ask Jess, that's even a little higher than she'd like to go. She'd like to be closer to 2 a month. That's to get everybody to settle in, make sure they know the staff, make sure they're with the right roommate, make sure we've gotten the right recreation for them, and it really needs to be a gradual, conservative fill-up plan. That fill-up plan we will match to make sure that we have the staff that we want on site to do that. So, we'll continue to hire and we'll continue to admit at the pace that we hire. So it won't be that we have all of a sudden have 93 residents with the same number of staff. Those two things will always match up. We know we need a special type of person to work with this population, that usually they gravitate towards us. They want to work somewhere unique. They want to work with needy people that are underserved. So we tend to get the right people. We have a very low rate of workman's comp. We actually made it 7 years without a loss of injury in 60 West. And I only mention that because that, if people were being assaulted or they were being hurt by residents or each other or whatever, that would come up. Basically, all of our workman's comp stuff is slip and falls. It's classic workers' comp things. Yeah. On which note?
Oh, number 5. Any impact that's running.
Well, okay, so certainly sorry about that. So that number was specifically about people being out in the neighborhood, like I'd mentioned before. So, one of the concerns was like, am I going to find somebody knocking on my door? Am I going to find somebody walking through my yard? We have zero elopements, 0.0 from any of our facilities in this regard. That is something that is obviously a concern for us to make sure that we have all the controls in place. So not only is it that they're not out there walking in the neighborhood with permission or with us assisting it, that just doesn't, they don't leave the center. That's the most direct thing that I wanted to say about the neighborhood. I know that that would be the consideration, is that you're, that there are folks that are, again, walking around. That just is not the case. It may well with Bennington Health and Rehab, it would not with our model. No. No, we would have to do physical plant improvements to have that courtyard in the back to be a full enclosed courtyard, and then we would do activities in the courtyard. But that's the current provider. Yeah, that wouldn't happen with us. Yeah. That is a more classic nursing home. I don't even know if we do that in other locations.
We do. But we do have plans, so in the backyard, there's a pseudo-beautiful area that will be leveled more, so that the plan is it's a holistic look to care. So the better people are, the more active people are during the day, the more engaged they are, the more successful they are, the better they eat, the less medications they need, and the better they sleep. So that's what you should be hoping for yourselves any day. So there'll be a back area because, yes, they will absolutely need fresh air and go outside, but it'll be in a secure courtyard. Yep.
Yeah.
These people come here to speak.
Yeah.
Yes, their questions. Sir.
Yeah.
Sir, it's time. Sir, can you do that?
Yeah.
If you're going to have questions, please direct them to the microphone, because the
Yeah.
people who are filming this can't hear you, so they can't hear the question unless you both can restate the question after it's asked.
Stu, I'm just here for support.
I
There's
understand.
people here that got
Yeah.
questions, and they're blowing a lot of time where these people aren't going to be able to ask questions.
Well, they have a right to make
Let the people ask the questions so they can
let
answer.
them make their presentation.
Well,
How much longer is?
that's it. So I apologize for running long. We wanted to make sure we got all the detail out. Here's my information, and we're ready to answer every question. I know they want to have folks use the microphone so it can be picked up for the camera.
So you're ready for
Yep,
questions?
by all means.
Yeah, I will, yeah. I guess I have more of a statement than questions, but maybe stuff that can emphasize and people here in town will agree with. So first of all, my name is Melissa Frechette. I'm a lifelong Bennington resident, and I've lived on Upper Putnam Street since 2016, when myself and my family bought our first home. So the main concern I have with this facility is the impact on our elderly population here in Bennington. As baby boomers continue to age, the need for skilled nursing facility is going to increase, and I feel with this new model, it's going to be taking away bed opportunities for our elderly population, and they're the ones that are going to be spending more times in hospitals waiting for beds. I feel like some of your language is very vague, so let's just emphasize you're going to be accepting patients from prisons and mental health hospitals that don't meet the criteria to go anywhere else. And on your website, it specifically states that they have chronic medical conditions, possibly coupled with diagnosed mental illnesses and behavioral disorders. So to me, some of these patients may pose risks. I have a 96-year-old grandmother in a skilled nursing facility, and placing her there was one of the hardest decisions my father has had to make. And I can't imagine people being in that position now, needing to place their family members, and where they may not feel safe. And the elderly in our town deserve better. And I want to make sure that for the residents of Putnam and Harwood Street, that we're not trying to give a not in my backyard attitude, but where this building is located, it's literally in our front yards. And I think every one of us in this town will recognize, and in the state, that there's an increased need for mental health services, recovery programs, which I believe some of your patient model does include recovery programs. I think I read something on your website about how you have Suboxone or opioid clinics. So that's going to be your facility too. But the building is literally, within just a couple hundred feet of residents. There's no secure area, there's no barrier between the building and us. And so that's, I think, a lot of our worry. And it just seems like this whole thing has been tried to keep under the radar, where the town never even knew about it until Mary started talking about it. And, and we deserve more honesty with that. I've watched my town taxes go up year after year since I purchased my house to now where they're almost double of what we were first paying. And now I have to worry about my property value going down because of what this facility might pose. So I think that's a lot of what we're feeling. And I think there should have been more openness around this. So thank you.
Good evening. My name's Norm LeBlanc. I'm also a resident on Putnam Street. I've lived there for a lot of years. When that facility came into play, we were promised on Putnam Street that they wouldn't be using the road. Putnam Street wasn't connected at that one time. There wouldn't be truck traffic. There wouldn't be car traffic for the staff. I've lived there for 30 years now. The truck traffic is crazy, the staff is crazy, it's a speedway. When they shift changes, I can tell you exactly at the times that they do it. And now you're talking about a 44-person facility that they have beds, going to increase it. So pretty much it's going to be double, if not more. Okay, because your staffing is going to get bigger, agreeably so, it has to, right? You're going to have more residents, going to need more trucks, more facilities, more hauling, in and out, garbage, food, whatever it happens to be.
We have masks thrown on the ground all the time. They throw their garbage out as they drive down the road.
You know, I see your first slide and it talks about hard to place individuals. There's a reason that they chose a life to become hard to be placed, not me. I served my country for 24 years, 5 combat tours. I live on Putnam Street because I like it, and it's nice. And I do not wish to live next to people that have been incarcerated for other things, okay? If you want to create an aging facility and we're going to house people, I understand that. We're all going to get old. I agree that we need to take care of our community and our place and be able to house the people. In every community from the country, from here to California, it's not the same as when we grew up 20 years ago. But it's not fair that it gets forced into my backyard, and that's just my opinion, and thank you.
My name is PJ Beaumont. I live on Prospect Street as well. You've had a mature operation in Connecticut for over a decade, and you should have ironed out all issues there by now. Is that correct? Well, on February 21st of this year, your vice president stated in sworn testimony to the state of Connecticut asking for more money. They're always going back asking for more money to try and lure workers to your facilities. We are still faced with retention issues and hiring quality staff. Our current retention rate is about 40% with new hires. On top of that, we are still reliant on agency. This causes issues with consistent care and also adds to increased costs. So are they going to keep coming back to the state of Vermont asking for more money? And it sounds like they're having issues with staff. Then the police coverage. Our police department is understaffed right now, and it's not going to get better soon. On your small 60 West facility, you've had 69 police calls in the last year. In your Manchester, Connecticut facility, you've had over 200 police calls. So, you know, is this going to turn into a you-know-what show or what? So anyways, thank you.
Hi, thank you for being here, for everybody. My name is Rebecca Souza. I'm a doctorate of nursing practice. I'm a professor of ethics and epidemiology. I'm also an advanced practice registered nurse with a specialty in geriatrics, palliative, and end-of-life care. And so I have a very big concern that Vermont is the 4th aging state in our country. Bennington County is the 2nd leading aging place in the state. And so I fear that the Dale commissioner has taken away future care from our elders who are already here and who are aging. There was data from 2019 that showed that 40% of the population in the lower 2 counties of the state were seeking care outside of the state. And I understand that there are 100+ patients needing to come back into the state, but this seems like a plan that is only supporting residents to continue to get their care outside of the state.
There's,
My name's Jeff.
I'll just take a quick second to answer one of the, or not answer a question, but clarify with the 100 folks. There's not very many people out of state, and it's not all about bringing folks back. Most of the folks are in hospitals and in settings in state, but there are some people who went out of state as well because they couldn't find it in state.
My name's Jeff Berry. I live across the street on Harwood Drive. And just to piggyback on Norm's comment about the traffic there, and if it gets worse, currently all the signs that are laying on the ground and I had an 18-wheeler drive directly on my front lawn last year after I was done mowing, and because he got stuck trying to take a left-hand turn there with the signs are just laying on the ground. They've been there for like 1.5 years, 2 years. So maybe you guys will do something different there. And currently, residents and patients do get out by themselves, because I've had that. They've come down pushing the IV poles, smoking out front because they weren't allowed to smoke up on top. So they come down the street and do that. But I think it's a good thing that you mentioned on that one page there. Well, you said the residents will not be walking outside of the center or the neighborhoods, but I told you that. Individuals needing physical rehabilitation or treatment in order to return to correction setting. That's at least something good for us to hear, because that was one of my concerns. But I just thought I'd bring that up.
Hi, my name is Kelly Carroll. I've been a resident of Bennington since 1969. I grew up here, I've raised my 3 children here, and I've lost a child here. I want to thank you for taking the time to actually come to Bennington for this. I do appreciate that. I want to let you know that since I've lost Emily, I have followed legislation regarding mental health and placement in facilities. You know, we've talked a lot about S-192. And I want to, first of all, apologize if I misuse the term forensic in my communication with you, because I listen to what they say in the legislator and DMH and Dale, and they talk about people like the guy that killed my daughter and trying to find care for him, and he's going to go in probably, hopefully not, but probably into some type of a mental health facility. So forensics might have been a little bit too technical, but you are justice-related, court-related, criminally adjudicated. And adjudicated, for those of you that don't know what that means, and you can correct me after, basically means if you have some type of an issue and you're not found competent, you're adjudicated, which means you're not found guilty and the charges just kind of disappear or they're not really pressed. So my concern is that those type of individuals are going to end up in a nursing home, and I will honestly tell you, I firmly believe that they do not belong in nursing homes. I know there is a huge push within Vermont now to get rid of our prisons, and if you're looking for a place like that, I think as you downsize Southern State, you should consider converting a ward there. I know Representative Morrissey worked really hard to get this meeting. I firmly agree with what you said. I think that asking in November about it, I feel she was a little bit misled. It wasn't really going to go forward. We really didn't have the opportunity for a meeting until tonight. Again, I appreciate that. But, you know, really, as far as Mission Care goes, it wasn't really hard to research it. So I looked you up. You got Holyoke, which you don't really talk about a lot. You talk a lot about Connecticut, but you don't really talk about Holyoke. And you've had that since 21. And in 2023, you had the DOH survey. There were 19 deficiencies. Several of them, the majority of them were nursing related, dignity related. We emailed back and forth about that a little bit. And I understand that you said, it was an older building and it's agency nurse and staffing. I asked you about turnover. You told me your turnover for Holyoke is 87%, which is significantly higher than the 40% retention you were talking about with Connecticut. The thing that I think is when you talk about that facility, and you look at the 19 deficiencies, and a lot of them were nursing and dignity related. There were medication issues. There was the wrong medication, which I'm sure that person absolutely felt horrible about dispensing. There were filthy wheelchairs. And the thing that really bothered me about that was how many people in the facility turned a blind eye and just walked the other way and looked the other way. And to me, that seems like a failure in leadership. It seems like a failure on the policies and procedures, either in the implementation of them, in the drafting of them, the follow-up, the training. I think if you do have agency nurses, they should be held to the same standard as our local staff and nurses that are working for our residents and our patients. And I don't see where that's the case. It was very easy to find on the government's website. So I guess my question is probably for people maybe who aren't here tonight. I would like to know, and first of all, thank you for the 36, noting that there are 36 nursing homes in the state. I have not looked them up, and I don't know what our average level of care is. But I'm kind of wondering if Governor Scott, Secretary Samuelson, new Commissioner Bowen, and Dr. Levine think that a facility that has a 2-star overall rating had 19 nursing-related deficiencies, $63,000 in fines in 3 years, and an 87% employee turnover rate is good for Vermont. And, I know that you said, oh, it's 2 years, it's the old owner. It's really not. It's Mission Care, it's eye care, and maybe you're going to wait for the new survey that's going on. I don't know, but I would just like to know if a 2.0 star rating is sufficient for Bennington and Vermont. Thank you.
I'll address that because I think it's great that you did the research. The research is out there. It's all public knowledge for nursing homes across the country. We are more regulated than nuclear power, so that you can absolutely research it. We are the most regulated entity in the nation. I thank you for that in regard to Mission Care. We did talk a lot about them. We would have more, but we wanted to give time for everything else. I can address every one of those deficiencies. I will tell you that as you read, and I appreciate your homework, there was never a widespread issue. So yes, there was one dirty wheelchair. Yes, there was one time for other things, and they were all one-offs. It was also unfortunate due to COVID that it was also a 2-year cycle. So nursing homes are supposed to be regulated every year and surveyed, and they were not. So that was 2 years worth of data, which unfortunately it is what it is. The nursing homes have hurt the most for COVID, and we strive to do great things, and our goal is to be a 5-star, and some of our turnovers because we have high expectations, and we're going to get people who want to come to work every day and want to care for people, and that is hard. And we are doing better, and we will do better, and we'll do better for Bennington as well. So thank you, though. Great. I'm happy you were educated.
But the problem is, and I didn't mean to interrupt you coming up, is we have heard time after time of all the good things you do, and I'm sure there are some good things that your organization does, but you always, instead of working like even with David said about staff, I asked that one of the first questions, how are you going to get staff? And you said, well, that's kind of a good question. I said, our hospital and all our other nursing facilities, as well as our visiting nurses, have a struggle. And you said, well, maybe we can add a few more dollars. This was your exact quote. And I said, all this is going to do is poach possibly people from another area. It doesn't solve the problem, and to have good qualified people. So, people want to hear the facts here, not a pretty PowerPoint, that's great, but that's what you're hearing, the concerns and upset from these folks. We just want the honest truth of what's going on.
For sure. It's only pretty because he knows how to do a PowerPoint, but for sure. So the transparency is that staffing is going to be the biggest challenge. And we've said that from the beginning. We've said it to the staff there. The staff there that fundamentally is from Bennington and local are fabulous people. And a lot of the pool that is there right now, the agency staff is as well. They've done a great job of trying to recruit some of those pools because same thing, yes, pools should absolutely be held to the highest level. The other goal is you want people who have skin in the game taking care of your residents, because that's how you're going to create the culture that you want. And that will absolutely be the goal. Will there be some changing of nursing home to nursing home and hospital to hospital? Yes, that's unfortunately reality. That's reality in any community. We're working with the chamber in regard to the relocate to Bennington, in regard to relocate to Vermont, also in regard to housing. Housing is a struggle right now. So doing our homework in regard to some of the new stuff that's coming in so that we can help provide housing and encourage people to be, taxpayers for Bennington as well. So that's just the tip of the iceberg. But we have a lot of work to do, definitely.
Thank you. My name is Louise Santelli. I do not live in the vicinity of where you want to put this. My main concern is mental health is going to happen. UCS in Bennington has a very good hold on that community. It's the criminal placement that I'm concerned about. Is this going to be on-the-job training, or are they going to come trained? This is a scary atmosphere. If you do not realize escalation, okay, the signs of escalation, there's going to be restraints involved. People are going to get hurt if they're not trained properly. Come trained. I understand from what I'm reading, training will be under supervision. It takes experience. So are you going to be bringing your workers into the community from another location? How is the training going to be done?
So do you want a job at Mission Care Bennington? Because it sounds like, I said, do you want a job at Mission Care Bennington? Because it sounds like you're qualified.
I worked that field already, and I loved it.
I'm like, what's your name? I'm going to call you later now. So great question. So yes, the answer is yes. So the current staff that's there will be trained that are already there. So we'll train them on de-escalation techniques, on identifying antecedents, on handling triggers, and all of the above, because the mental health side of it is the more challenging. And I'll be very clear about that. I have 14 years of experience at this point. I am the administrator of both of these buildings. It starts and stops with me in the excellence. And the Department of Corrections population is the most benign of what we're going to serve in that regard. And that's a huge stigma to get over, and I understand it 1,000%. We're going to be great neighbors because we're going to be quiet neighbors, and no news is good news. And but I am going to look into those signs regardless of whether or not we're in the building or not. So back to your training. So the people that we do hire will be trained prior to...
On the job?
Correct. So like we hire them, they'll be trained, they start. And then there's always on-the-job training, because there has to be. So there's the initial training to get the fundamentals, and then there's always on-the-job training to retrain, to refresh, because you can't just do it once and think it's always going to stick. So it's constant. Knowledge is power, and we really believe in that. So yeah, so that's a great question.
It's a scary atmosphere. Yes,
Sure. Not the corrections part, though. That's the easy part.
Thank you for giving us all this opportunity. I'm Trevor Currier. I've lived in Bennington for 27 years. My concerns prior to coming, you have addressed a little bit. My concerns obviously have been the protection of the residents at these homes, the staff, because you're talking about some 25-year-old girls that were trained to administer medications and take blood pressures, and now we're getting the impression that they're going to become more low-grade prison guards to deal with the possibility of some of these inmates, or excuse me, some of the patients that are transferring in possibly. You've addressed some of those with the PowerPoint in very rosy, politically correct language. So but I think that's a concern everybody shares here. The question I have is actually more towards Stu and Representative Morrissey, is that I think everybody here would like some information maybe on the permit process. I'm sure there's building use permits and that type of thing. Are these, what is the process for attaining these? Are there an expiration date? How frequently are these permits and licensing renewed and reviewed? So that if some of the problems that the residents are concerned with, if these come to fruition, are we, for lack of a better phrase, now stuck with it? So maybe you could deal with some of the town provincials on that. Thank you.
Because this is already a nursing home permitted by the town's land use regulations, it can continue to be a nursing home. It will always exist in that form until it changes its use. It is permitted where it is located. If they do major renovations involving any kind of building code renovations, they will require a building permit from the town of Bennington. Most likely there would be other permits required from the state as well because of the nursing home atmosphere in which they are working and building. But as far as changing what is, this facility is here, and as long as there is someone here willing to operate it and be licensed by the state of Vermont and the federal government, it can be here and it can exist here. There are no expiration dates on building and zoning permits that are issued once the construction is completed.
I just want to add one piece is the licensure from the state. So every nursing home has to be licensed, and there is a recertification, correct? How often does that happen?
2 years.
Every 2 years. And a part of that is a survey from the state, and it includes all of the clinical and safety components that are required by the federal government. In rare cases, there are nursing homes who don't make it because they've failed to meet the standards that are set under that licensure. But that is one part of the picture as well. I just wanted to make sure folks knew that.
But I did ask the question because it was going from a regular nursing home to this now higher capacity of individuals coming with different issues. Does that need a different licensure? It should, because
it does not. It does not.
So the upstairs, it would be on the third floor, would be the different population? Or would it be downstairs? Where would it be?
They're going to, the population will be wherever they need to be.
Okay.
Yeah, for diagnosis, for roommate compatibility, all of the above.
So
The entire facility will be specialized, not just the secure unit.
Correct. The whole
I thought there was going to be a secure
picture for
unit,
the program is the whole building, correct.
So it's not going to be a secure unit, it's going to be a secure building?
Correct.
So to speak. Okay. So keypads, people can oversee people putting the codes in. I've seen it. Is there a way to change that to maybe that the staff has to use their badge to get in and out versus a keypad?
Yes, as a matter of fact, there is. And we do utilize those in our other buildings.
Will that be happening there?
Yes. Yep. It's amazing, because I'm sure you're using a different example, but it's amazing how a dementia resident who can't tell you who they are can figure out that code. So we've avoided that by using the other. Yep, that's a great question.
Hi, Norman Blank again. Question is for the director. I know you said earlier in your beginning statement you put up RFPs, requests for proposals. How many companies responded to that? You probably not. You probably can't answer the question of which ones were, but what were the reasons the department, the director, your agency picked iCare? Why were they better than everybody else? Was it, did we have multiple people, or is there a certain reason? Thank you.
Thank you. That's a great question. There were 4 applicants, and when the contract is signed, that will actually get, the information will be public, but I can let you know that there were 4 applicants, and it was really about the specialty care that they brought to this, and having done the complex care in the past, they were the only ones who had that intentional kind of model of care who had applied for the RFP.
Sam Rustino, Bennington, Vermont. I have a few questions. You mentioned about staff. I want to know currently how many are you going to be hiring, and if you're going to be hiring quite a few. We've got a housing issue here in this town and the surrounding areas. Where are you going to house these people that are going to be staying and working in your facility? Secondly, first responders, when they do respond, if this should happen, this deal goes through, do you have an incident in place that there's certain code levels? When we get our fire department, our police department, our rescue squad, are you going to be very strongly transparent with residents and first responders and the town and a Facebook page when an incident happens? Thank you.
Well, in regards to the public safety part, we had conversations with the chief of police and with Bennington Rescue, and I think it was the chief that wanted to do tabletop exercises, and
Correct.
so they are interested in, obviously having access to the facility, being able to get, through whatever doors they need to be, all the different access pieces, and also understanding. He has to do a tabletop exercise, so being able to drill there and really understand how the building functions and, fire safety, life safety, all those things.
So that's just sort of, not to get into the weeds about nursing homes, but there's a significant focus on emergency preparedness. So when we met with the chief, we went through a lot of that with him, because it's super important that, if there is indeed a fire or anything like that, that they have access. So they'll have the key code, where did that gentleman go? But they'll have the key codes to be able to get in. We'll always, as a nursing home provider, celebrate that relationship. It's super important. Also, not to get in the weeds, but to understand when someone is, we're talking about calls from public servants. It's unfortunately or fortunately, it's a regulation that they are notified if there's ever an incident. So it could be a very minor incident. It could be something that we're reporting to the state, and it's something that they have to deal with. But it's minor stuff. It's not because they're coming because there's people in fisticuffs and the staff is trying to separate them. We don't restrain in nursing homes. That's the difference between what we're talking about with different levels of care. We can't give somebody, we can't hold somebody down and throw a needle in them to calm them down. That's the picture you have, but that's not the picture of how we can function and do function. So it's mitigating all of those risks to never get to that point. We will not be a acute psychiatric hospital or unit, and we won't be, we're a nursing home. We won't be an inmate unit. We'll be a nursing home. Super important to understand that the people that are there right now, in talking about the Bennington versus the Holyoke model, we did bring residents together. They've done a great job of living together. They really, you've seen by the pictures, those are not all professionally done, but those are people that live there in harmony. They're great with each other. And the other piece of that is the stigma that it's a prison nursing home. It can't be. We're a nursing home. They're not inmates. They're nursing home residents. And we have a greater responsibility to keep everybody safe. So we're going to do that to keep the people that are safe that live there. So we're not going to bring someone in knowing that it could be a risk to someone who already lives there. And because they're not a risk to someone who already lives there, then they're not going to be a risk to someone who works there. So super important to understand. And it's everybody. Thank you.
Hi, my name is Chris Souza, a resident of Bennington for not too long, but there's things in this town that's starting to concern me, and this is one of them. My first question probably goes a little more towards maybe even the state to answer, but you guys might be able to chime in. Has there been a certificate of need completed and filed for this project? And has it been approved by the state already? I also wonder why the Department of Mental Health is not involved in this meeting tonight, or have they been involved at all since this started, as you are going to take on mental health patients? Finally, something else I'd like to ask, because I do have concerns about the community. You do talk in one of your slides about protecting the people coming into that facility that can't protect themselves. But what are you planning to do truly to protect the people of the community? Because when your deficiencies right now that you're getting written up for during inspections are things as simple as a dirty wheelchair, where is the help to stop those people from leaving the building? A little keypad, things like that, that's not going to do it. So if your staff right now can't clean a wheelchair, how are they going to protect the community and keep those people from walking around the neighborhoods where we all live? So, thank you.
Thank you. So I will try to answer the first question about the certificate of need. The Green Mountain Care Board manages certificate of need applications, and when a nursing home sells, a certificate of need is not necessary, but a transfer of ownership application is required, and that's a part of a purchase of any nursing home. And so a transfer of ownership application has been filed, and that process has been completed through the contract. So I mentioned earlier that the contract still has to be finalized, so once that's done, then the transfer of ownership process will be done as well. And the second question was about Department of Mental Health, thank you. Yes, the Department of Mental Health, it's a great point. They're not here, and that would have been really helpful to have them a part of this conversation. They have been a part of this process from the beginning and helping both the Department of Corrections, Dale, and the Department of Mental Health to figure out what the need is and to help craft the request for proposals. And they've also been a part of helping to identify people and are now also a part of assessing and the next phase of kind of identifying folks who could use this service and who would be appropriate for this service. So they're partners in this process from the beginning.
And the other was a great point. I'll just reiterate that we take care of nursing home residents, so they're not a risk to each other, then they won't be a risk to the community. I mean, even the ones who are there now under Bennington Health and Rehab have the right to go for a walk. The difference is our walks will be in a patio and not in your neighborhood.
My name is Barbara Lassoff. I'm a Bennington resident. I just wanted to go back to the zoning. Since there is a Department of Corrections aspect to this, is that right, that there's no zoning change required?
It's a nursing home.
But it has a Department of Corrections clientele.
Nursing home is a definition from a land use regulation. They're going to be operating a nursing home. Who comes in and how they come in, that's a state and federal regulation that they have to meet.
Okay.
Hi, good evening. Bob Ward from Dewey Street in Bennington. I just had a question on slide 8. It says special population care recovery substance use disorder, and under that it says PHP/IOP. Those are supporting programs, and that's intensive outpatient program and the partial hospitalization program. So I guess my concern is they're going to be treating people on an outpatient basis. That's a big concern.
So there's
That's a very big concern.
There's two things about that. So what you're describing is what we call an iRecovery program that we run in Connecticut in 4 centers. We won't be running that here. And then the description of it is it's a partial hospital intensive outpatient program, but delivered inside a nursing home. So even when we do it in Connecticut, it's all the things you would do out in the community outpatient, but it's brought into the nursing home while they're there for their treatment. But we won't be doing it in
So
in
you
Vermont.
guarantee there's going to be no outpatient treatment, drug treatment program?
No.
Okay.
No.
And then I guess my other concern, just kind of a follow-up, from the Holyoke Police Department response, the quantity of responses, that's a deep concern because everybody knows the police department in Bennington is really stretched really thin.
Yeah, we typically, like I said, we run less emergency responses overall in these types of centers, even as compared to our other own nursing homes in our group, because there's no short-term rehab. That's what usually brings the ambulance there, because you have sicker patients when you have short-term rehab, medically sicker, and then police tend to be in more in other nursing homes because we have more recreation, we have more infrastructure, we have more consulting physicians and services to keep those things from happening. So that's why we keep bringing up that letter from Rocky Hill Police that shows that we're drastically less than all the comparable nursing homes in Rocky Hill. And we'd expect that the same thing would happen in Bennington.
Okay,
but we have
thanks.
been in touch with the chief. I mean, he's going to know very much so how to get in touch with me if there's issues or with us.
Yeah, we did hear the chief actually speak about it. He said he did have some conversations with your staff about it, so. I just, time will tell on that, I guess. All right, thank you.
Hi, Kelly Carroll again. This is for Dale. You had said in 2022 that the RFP went out. There were 4 providers that applied back or responded. iCare was the one that got the bid. When we emailed a week or so back, you hadn't gone on site yet. And did you make an on-site visit since? Okay, so I just think that for me, it's really, really hard to go on to the government website, see the 2-star rating, see the 87% turnover that he told me about, see the 19 deficiencies, and hear about how great this is when it's been 2 years since the RFP went out and everything came back, and nobody from your organization has even taken the time to make an on-site visit to validate that it's as pretty as the PowerPoint is. So that was just a comment. Reply if you want.
Hi, my name is Michael White. I'm a resident. I'm actually a neighbor. My question is about leadership. Who's going to be the director? Because to me, leadership plays the huge role. They're the people who oversee, they're the people who hire, they're the people who will have the real control. I'd feel a lot better if I knew who the leadership was, if I heard them talk, if I heard them speak their philosophy and their feeling about this change. Has the leadership been hired? Where is that process?
Sure, great question, thank you. So currently the administrator there the plan will be that she will continue to practice there. So she is currently the leader at Bennington Health and Rehab and will be the leader for Mission Care Health. The director of nurses has history with Bennington Health and Rehab, and we've hired her, and she is now orienting to the program, to the culture, just to the company to get oriented. So she will be, once we've taken over the building, will be on board. The staff there has been great. We've offered everybody who is there, so department head-wise, leadership-wise, to housekeeping and laundry, which is just as important in regard to how that's going to work. A leader is as strong as any staff member. And they're all been very receptive, and it's been actually wonderful to interact with them. It's going to be exciting to be able to lead them and to be able to train them and work with them. But that's a great question.
And just to be clear, any of these projects Jess is intimately involved with. She ran 60 West, she ran Mission Care at Holyoke. So she'll be on site, I'll be on site on a very frequent basis. And then part of how we have this set up is that we have a corporate team or central office team that is a subject matter expert for these things. So I oversee our admissions team and work with them, but we have a vice president of psychosocial services who consults with the social workers and behavioral health leadership. We have a senior vice president of operations who helps with the staffing piece of it. We have a business planning. We just have a lot. That's part of what we bring to the picture, is to be able to bring in people that have done this in other places and actually be on site and physically here to make sure that the launch goes well, everybody understands their roles, that the training that's needed is being deployed. So we'll be heavily present as long as it takes for it to be well ingrained into the program.
Melissa again, and this time I have a question. So in keeping with the transparency, because I feel like tonight we've heard the word if a lot. If this happens, if this happens, if this happens. And the fact of the matter is, this is happening regardless of our concerns in the room. Bennington's been added to your website. You've made announcements for administrative staff. You've talked tonight about staff that you're hiring. So in changing the if to when, because again, this is happening whether we want it to or not, when do you anticipate admitting the new patient population that is planned to go into this building? When can we expect this changeover to occur?
So, good question. So, right now the plan is for April 12th to be the date that we would assume the operations. That, I think has been pointed out a couple times, has changed a few times. When it originally was planned in the fall, we ran into some late concerns with the operator and the real estate. It's just a contractual problem that delayed everything. We didn't know that it was going to get back on track. It literally became a complete question as to whether we would be able to put it back on track. We were able to do so with the seller. And then right now the last pieces of the contract with the state are being worked out. Once we assume operations, we have to do all the things that Jess has kind of described, where we have to be physically in the place, we have to meet with the residents and staff again, we have to set the groundwork, a baseline as to where we're at with them. And we have to do training, we have to staff up, and then within a couple of weeks of assuming operations is when we would start considering the first admissions to the program, which again would run probably in the order of 3 to 6 residents per month. So let's say that we did really, really, really well in April and we were comfortable by the end of April, you might see 1 at the end of April, would probably be my best projection.
Rebecca Souza, thank you again. A comment on the current leadership. The current leadership led the building to 36 plus deficiencies in their last annual survey, placing Bennington Health and Rehab on the CMS specialty watch list. I would be interested to know that if next survey the building does not pass, if it would then become a CMS specialty facility.
So yes, so I'm trying to be polite to the company that's currently there, or respectful, I should say. So yes, it is on the verge of being a focus building. This goes back to the staffing and the training that they do or don't have. And so what we will do when time comes will be to train the staff. There is a certain level that is necessary for caring for our population. And when I mean that, I mean the nursing home population. So it'll be training those that are there, that have skin in the game, and then it'll be training those that come in as pool, hopefully temporarily, optimistically. The good news is they do have travelers who stay for a little longer so that we can hold them to the high standards that they all should be held to. And the expectation would be that they will not be a focus facility by then. And that's the goal. So we are aware of where they were. This past survey was better, but there's a lot of room for growth. So we will do that. But it goes back to the training that's involved as well, and the supervision and the leadership to hold people accountable. It's a great question. You're welcome.
For the commissioner, I'm just wondering why the state hadn't selected a new building. It sounds like this is a very thriving company, eye care, and with thriving, I would expect there to be finances to build a new facility versus taking one of the facilities offline.
The request for proposal that we actually came up with was pretty broad. So we invited either existing nursing homes or ideas for new places, or a facility or a business like iCare who purchases a nursing home in the state. And we did not get any requests for proposals for brand new. One thing that doing a brand new facility is it takes also a lot longer to stand up, and there is a certificate of need process for a brand new facility as well. And I would love to catch you after, because I'm really interested in the data that you are looking at for the number of nursing home beds for folks who are aging in the county. The data that I have, which is from the Department of Health, shows that people 60 and older, that Bennington County is about in the middle of the pack for folks who are 60 and older, and the total number of beds for people who are 60 and older is among the highest. So I would love to compare notes because I want to make sure I'm not overlooking something.
I'd be glad to share that with you. I actually wrote it in a policy brief to the Department of Nursing.
That would be great. Thank you.
Nancy White, Bennington. Commissioner, why weren't you willing to come here in November to talk publicly to see if Bennington residents wanted to lose these beds that have been available for the general public of this town for 50 to 55 years? Just a few weeks ago, I thought I'd heard that practically all of the rehab and nursing home beds in the state are full, and already facilities for quite a while have had a tough time trying to find placements just for the general public. I'm very concerned that I'm hearing we have to worry about people across the state and outside the state coming to Bennington. I'm worried about what Bennington residents are going to do when we lose those beds. I can remember a time when that was full, when all the 90 beds were there, and we also had Crescent. I don't remember if CLR was open, but to be left just with 2 nursing homes in Bennington, I think it's going to be a real issue and a problem for local residents or the people from nearby towns. We recently, in the past couple of years, lost 2 longtime community care homes. We have 1 left. I'm aware maybe a decade ago, a large nursing home in the White River area closed. Nobody's opening nursing homes. And again, to have the 4th highest population of seniors in the country, I don't see the state doing much as far as nursing homes go for actual seniors. So I don't know if this is a done deal, but I would love the state to find a different facility rather than Bennington. I mean, we draw from Massachusetts, we draw from New York State. Many local residents have elderly parents come, and sometimes they need to go to a nursing home. I'm afraid that in 2 years, we're going to have Bennington residents that are going to have to be going 30, 40, 50 miles away for a nursing home bed because they won't get one locally.
Thank you. Your first question was about the November timeframe and why we didn't come down to the town at that time. And Dave had mentioned that there was a serious challenge with the procurement at that time, and it was very possible it wasn't going to happen. So that was a real thing, and so we just made that decision not to do that until we knew what the outcome of that was. With regards to kind of choosing, so this is an interesting situation because it's not the state purchasing, it's a private purchase, sale and purchase, and that happens throughout the state, regularly when a nursing home sells. What is intentional is we are working with iCare, who has the experience, so with how to provide that actual model of care. But the purchase and sale itself is a private arrangement with the business to purchase a nursing home. So we don't, and then they have the ability to apply for a transfer of ownership, and we negotiate the rate at that point. Does that make sense?
But the state was very involved starting in 2022. And when I read your interview, it sounded it was a done deal that was going to start in December, and I believe you said you hadn't wanted to start from scratch. Well, by using Bennington, I think you're putting a lot of local seniors in a position they're not going to find a bed locally in a year or two. And
I understand your concern. I know there was a lot of mumbling because it sounds like there's some really good information that I don't have from that report. I'm talking about the data that comes from the population data and the nursing home bed data. It shows that Bennington has the most beds. It doesn't relieve your concern, but number-wise, it has the most nursing home beds by county. So that is a reality. Again, it doesn't, I'm not saying that alleviates your worry about that, because we have an aging state.
Your population in the state, in the county?
It's off the state's website.
So it's a hard thing to do from up here because the information that's in the FAQ that I provided, and that's why I want to go back and verify, because that's from the Department of Health population estimates. And maybe we're looking at apples and oranges. That's the number of people who are age 60 and older in the county, and then that's compared to the number of nursing home beds by county, which is the table at the back of the FAQ, and there's a link to the website where the data came from. So that's why I would love to compare notes on that.
Hi, my name's Dr. Gerald Rogo. I retired here to Bennington after closing my practice in the New York City metropolitan area in 2017. I live in the house overlooking your patio. I noticed that you conveniently forgot that we're going to have people there on the sex offender registry. Also, you've admitted that we will have people there who are ambulatory. That doesn't instill a lot of trust. Look at the number of older women that we have here in this audience, and you chose to not inform them that sex offenders who could be ambulatory are there. Why should we believe anything you have to say? Second of all, as a doctor, we run the gamut. Those who are competent, those who are incompetent. More often than not, doctors who are on the verge of losing their licenses end up working in institutions like this. They make the decisions. Will there be any transparency? Will you provide the neighbors, the town, with disciplinary actions, malpractice, things like that, that the physicians have that are making the decisions so that we can decide whether they're competent or whether they're just holding on to an income before their license is revoked? Thank you.
My name is Tom Blakely. I live on Elm Street, right around the corner from Putnam, and some of you have probably seen me running through your neighborhood. I do that on a regular basis. And that's okay. Barking, I don't mind. I run by your facility, well, what will soon be your facility, and I wanted to talk, you've had a tough audience tonight, and I want to talk a little bit about community relations. Because I don't think you want your facility here, I'm assuming it's going to be here, it sounds like it's going to be here, I don't think you want it to be a black box that regularly spits out problems for your neighbors. And it sounds like it has some of that as a history. I run by there, I've seen some of the down signs and the trash on the side of the road. I've had to evade a couple of I will say sporting drivers on Putnam on occasion when I'm running. I think you really need to consider how you make yourself a valued part of the community, and whether that's a community ombudsman that we can take our problems to at any time, or whether it's regular, and I mean monthly, not once a year, meetings with the neighbors to address any of their concerns. I think some of what I'm hearing tonight would be addressed by that. I don't think all of it would. I don't think all of it can be. I think the shortage of nursing home beds is a complex problem in Vermont because of a number of things, the very low unemployment rate, the lack of housing stock that we're all in dire need of additional housing, and that's going to be a problem for you bringing people in. But I think focusing on the openness, the transparency, and the communication with the community is going to be a big plus for going forward from here. Thank you.
So I appreciate that comment. So to your point, we've actually done something. We haven't hired a director of community relations at our other centers necessarily. It usually comes from my office. And in Vermont, we did decide to hire a director of community relations specifically for Bennington. That individual is Chris Oldham, who I think is fairly well known to folks. He's currently the marketing admissions director for the current provider, but as soon as we assume the operations, he's going to move into that community relations role. In regards to the rest of it, absolutely this is going to have to be a proof in the pudding thing, but the reason why I have all my stuff up here is because you really shouldn't see anything change other than the sign. And I know people don't, I've used that before and people aren't thrilled with that as a phrase, but it's true. You really, if we're doing our job well and we're doing it correctly and we don't have any room for error because of what we do, all you should notice is that a Mission Care Bennington sign goes up. We clean up the signs that have been damaged and address any of this garbage that's being thrown out or anything else. But other than that, 60 West, Mission Care at Holyoke, none of those neighbors have ever had an issue with us. They've never detected anything, they've never noticed anything, they've never reached out for anything. That's our goal. As Jess said, no news is good news. We're supposed to be heads down, focusing on our mission, doing it correctly, and not impacting the people around us. And so all of those people walking around smoking cigarettes and IV poles and all that stuff should all go away once the operation is assumed by us.
And I do appreciate that because we had a great meeting or call with the care coordinators, the discharge planners from the hospital, and they too voiced some of their current frustrations with the building. So those are all on the to-do list to know those are concerns, and so is the trash and the garbage and all the other stuff. So you will see those differences. You should see those differences. So should the residents. So thank you for your feedback. It's important.
My name's Tom Crow. I'm from Bennington. I was listening to all of this. I didn't realize it was going to snow so early. Logistically, one thing that came to my attention was you're going to have Rescue Inc. come over here for your mental transports. Is that the way I understood this? That was on the sheet?
So the way it would typically work is if there was an emergent situation, it's obviously going to be through 911 and Bennington Rescue Squad to the local ER. If we had a situation where somebody looked like they needed more medication management or they needed an acute psychiatric stay, you can generally predict that in advance with the psychiatrist and the medical director having a conversation, or the psych APRN, and them saying they probably are going to meet the criteria, and they contact Brattleboro Retreat. And the retreat has an arrangement with Rescue Inc. to be able to bring people from. Yeah, so this would be a non-emergent situation where that would happen. Emergent would go back through 911.
It would go back to 911, which means Bennington Rescue will be taxed, which means the entire county will be taxed, manpower-wise. Are you aware of the shortages we have? Has anybody looked at that?
Yeah, I mean, we had a conversation with Bennington Rescue Squad about what it would look like. It shouldn't be any different than what their response to that building is now. It should not be any more.
We have people that are needing ambulances now that are waiting 20, 40 minutes for an ambulance.
Yeah.
Because they have to come from Granville because we don't have the staffing.
Yeah.
When they do transport a person with a mental breakdown or whatever, many times the police have to ride in the back. Are you prepared for that? Staff has to go with them and stay with them at the hospital, not just go up, hey, John Q's having a bad day, thank you, and then go back to the facility. They have to stay there. That's the current procedure, and that concerns me. I have 4 family members in nursing, 3 of them in residences not unlike yours. How many assaults have occurred in this current establishment right now? I know it's not under your watch, but are you aware of it? No. The police are up there constantly having to help out patient-to-patient assaults, patient-to-caregiver assaults. I mean, our PD is stretched to the max as it is now. This is without people with known issues coming into the facility now, the added facility. Currently, a lot is being assumed here and not really being looked at totally. I can tell you, yeah, we can handle that. But what's going to happen when it happens? Oh, yeah, we can handle it because we're going to call Who's It Falls to come up. Oh, they're tied up, so they can't make it, so we'll have to get Manchester to come down. Oh, Manchester's tied up. Now where are we going? And that's a fact. This is what's happening now. And these people have paid good tax money for services they can't get because of staffing. Why is the staffing so short at that facility? Do we know? Have we studied it? Is it because people get sick of being assaulted? I can tell you one nurse that was sick of being assaulted up there, and she left. I promised my daughters I wouldn't get arrested tonight. I will stop now before I am. Thank you.
Well, what's the fun in that? No. So yes, we talked about that a little bit before. Because of their census challenges, they have taken people who they wouldn't have typically, so they aren't currently equipped to handle them. So to go back to your comment and question about the training, that staff is very excited to get the tools that they need to care for people that we will plan to take, not that we're taking out of desperation to fill a bed that we don't know the information on, that we don't have the history, that they have not been stable for an enormous amount of time, so that we aren't having those issues. That's the goal.
There's a lot of things that the format that we're doing with the state allows us to do that another provider like the current provider can't do. And they get in this situation where they're under intense pressure to bring more residents in. They can't hire staff. They get a bad reputation, so they can't hire more staff. Then they have to draw from further away, and it's like a downward spiral. And what we do, and of course we're going to have to prove this, I can tell you until I'm blue in the face, but we're going to have to show it, is that we come in and we change that. We change the model. We make it a more appealing nursing home job because you're working at a very unique place. We end up paying better because that's just how it works out. And that's what we did in Holyoke. That's what we've done. We've only acquired 2 facilities in the recent past. One was Holyoke, another one was in Hartford. We acquired that one in bankruptcy, really bad regulatory history, was essentially going out of business, and the state of Connecticut said, we need you to come in and fix this, turn it around. As of yesterday, it's full. It's been a going concern. It's still a taxpayer in Hartford. That's kind of what we're known to do. But again, I know that we have to prove that, not just say it.
Hi, my name is Lou Wobchinak. I live on Putnam Street. You said before that you didn't come here in November because there was a possibility you might not get the place. Shouldn't you have come here before to find out whether anybody in this town wants you here?
I mean, I'm not sure that, so you have 36 nursing homes in Vermont. We wanted to find a location that was relatively close to a population center where we could draw staff from. We wanted to be close to a hospital that was, reputable and would work with us in a partnership format. We wanted to be accessible to us so we can come up and, if there's folks from our central office that need to. I know that it's probably not the favorite statement to say, but Bennington Health and Rehab is perfect for what we're trying to do for this. I know that that's not necessarily for you, but for us, it is a perfect format.
Does it matter to you that the people that live in the surrounding neighborhood may not want you here?
It absolutely matters. I just don't know that we would have a different response anywhere, and I mean, that's just being honest. And secondly, I would be willing to say that if I came back, here's my information, if I came back in a year after we assumed the operation, you guys would be like, well, it's been pretty quiet. I can say anything in this meeting, but you guys are going to want to see the proof of it. And so it's really going to be that we know that we're under that pressure every single day and that we have zero room for error. We're fully aware of that, and it's our commitment to make sure we're doing this right. And we have states all over the country talking to us about doing this. We have a lot of eyes on us. We know that we have to do it correct, and we spend all day, every day making sure that that's what happens.
My second question is for the town. Would there have been, the town been able to turn them away had they taken a vote in the community and the community said, no, this is not the type of facility we want?
No.
So this is like pointless.
It's a private business acquisition between two private. I'm sorry. It's a private acquisition We have a private company purchasing a nursing home from a private company.
Well, hold on, that's not completely true. No, that's not completely true because the state put out an RFQ. So the state is involved. No, the state is involved.
Am I allowed to speak?
No, not right now.
Okay, thank you.
So the state was involved. The state was involved, and I'm not going to blame iCare for this. I blame the state. Why wasn't the state down here even before November to have these conversations with the town? Because again, the state put out the RFQ for this to happen, okay? It is not, yes, the ultimate part of this does become iCare buying this from Genesis, but it still goes down to the state allowing the RFQ to go out. That's how it works.
The state saw the need, and the state put out an RFQ.
So the state was involved, whereas Bennington may have had a chance to stop it with the state if we said we didn't want it.
If we'd known about it.
If we had known about it.
Well, unfortunately,
the private sale part, I agree. It's by the end of the day, it's a private sale, but it was a state-issued RFQ.
Yeah, but the question to me was, could we have stopped the private sale? We can't.
Could we have stopped it from ever going to sale?
That I don't know. Because we didn't know about it.
Right, we should have known about it.
That's a direction to
That's on the back of our commissioner, because you should have reached out, and when I begged you to come down in November.
Just so people can hear at home.
And when I asked you to come in November, it should have happened. These folks are good folks in this community. They live here, they worked here all their lives. They've had family generations, and no one wanted to answer any of the questions. And I'm tired of being told that it's now a private between two nursing homes. No, the state is involved. Our Vermont Medicaid money is going towards this. So it's not just a private initiative. It is a public-private.
I'm actually afraid to go up there and see it. Hi. I think I'll lighten the air a little bit here. My name is Mary. I'll go by the mic. I've worked at the Vermont Veterans Home for a really long time, so I'm pretty versed with nursing home care and things of that sort. My question is, if you haven't visited the facility and you're going to be evaluating individuals, have you any idea of where people are going to be placed who have special needs or specific kind of needs? Because right now you're saying it's a nursing home. They're going to need care, but I don't know if there's any, have you thought about placements and separations and security needs? Because at this time, I don't think there's any real secure areas in the building, but I'm not sure. Are you going to be separating the judicial part of that, and what kind of, Okay, there we go. And I think the other thing that kind of concerns me is if, especially with the mental health and the judicial part of it, what's the average age, and is there a real concern for us?
Sure. So, all great questions. Thank you for your service at the VA. I actually
It's not the VA.
Sorry,
Vermont
I apologize.
Veterans Home.
The Veterans Home. I actually worked there a very long time ago. It's near and dear to my heart, and so is the fact that I'm also a veteran family, so thank you. At the same time, the residents, which are going to be nursing home residents, will be placed by diagnosis. So who they are, how they present today, not who they were 30 years ago when they committed a crime or when they were diagnosed with their mental illness. It's someone who is stable, who requires nursing home level of care, who requires assistance, and who needs care of LNAs and nurses, and the supportive staff around that. So there will be, we have thought significantly and specifically about security. And we do that to make everyone feel safe, but it's the people that we're admitting can't be a threat to the current population or to the population that we care for because they are the most compromised population in society. So we admit people that will fit the milieu to keep everyone safe in that regard. So to the question of, it's a 3-story building, so there are stairwells. So those will all be keypadded because you don't want someone careening down a stairwell. That's just not appropriate. And then same thing with the egress. It's just the same as we're keeping people inside safe as it is keeping people outside safe. It goes both ways. So yes, all of those things have been considered and will be implemented.
So you're going to be visiting the building?
We've been to the building.
You've been?
Oh, yeah. We've been to the building. We've spent time with the staff. We've done those surveys per se. Yes.
I think some of our concern is the lady whose daughter was killed. We don't want him back.
Sure.
Ever.
Completely understand.
Thank you. Thank you.
I know, actually, I don't know if you saw me saying that. I'm like, she had another question. I don't know yet here. So the average age at the other 2 centers, it could be 65-ish, but I'm kind of talking off the top of my head in regard to knowing the people. I'd have to go back and look specifically at the numbers. I will be very open that we have had people as young as 30 years old. Being incarcerated and having mental illness is not good for the body. They've been very ill. So they come in, not all of you will know this, but cancer, in regard to, we've had people with liver cancer who come in and they're bright as a highlighter because of their liver, and they are younger, but they're also at end of life. So we have run the gamut. The oldest gentleman right now at 60 West is 98, and I don't know the youngest right now, but it's not that young. So I think the mean is somewhere in the 65 range, 65 to 70 range. So I would have to get that for you more specifically. But there is a range, but they're also nursing home level of care, and they're ill. They're sick. But yes, it's a great point. Good, better, and different. You've been very educational in regard to the state of Vermont, so we will be cautious. And I'm sorry for your loss. Yes and no. They're right across the street. But I hear you.
So 2 things. One, the doctor had asked a question earlier about registered sex offenders and whether they will be didn't actually get an answer, which also goes to a question I have. So if they are going to be registered sex offenders, how is the community going to be made aware? And your hope is to start moving people in about 30 to 45 days or so after you've taken over. Are your security upgrades going to be in place by then, or what is that process? Because you're already planning to bring patients in without getting into the security aspect with us. My second question was about the staff. You said it's a very good staff, very knowledgeable staff, a staff that has, by your accounts, averaged about 34 deficiencies in their reporting over the last, consistently over the last couple of years, per year, right? 34 or so per year. You did say it was a little better this past year. So you're retaining them, but what kind of evaluations are you doing? Because if they're having all of these deficiencies, the quick scapegoat answer is blame it on the old company. But are they really the best people to have there, or are you just hiring them because they're willing to stay on?
So all great points. With the current staff, I didn't say they were knowledgeable. I said they were good people, fundamentally, which is important because they're caregivers. And I also said that we would be giving them the tools to do their jobs. So part of the tools is the education, but it's also supplies. It's also all those supportive pieces. Thank you for, because technically it ended up being a question, but in regard to the sex offender population. So yes, our other 2 facilities do serve a sex offender population. Typically, there's a neighborhood alert so that you put in your address and then you would know anytime a sex offender moved anywhere near you in the area. So if you aren't on that alert, you can be. I'm not sure if that's a system here. I would assume it is. Will we have sex offenders? Potentially. Are they, again, I'll go back to my point about the nursing home. Are they active predators? Absolutely not. There's no time where we're going to have an active predator in our building. These are people who, it's a past offense. They have not, we will look at their recidivisms. They would not be someone who has offended again, and it would not be a risk to our community, ultimately then to the community. So that's a great question. It was a great point. I don't know where he went, but to the above. So thank you for bringing that up again.
It could possibly be on the registry.
Yeah, absolutely. Yep. So we won't know, but potentially we do serve that population.
My name is Kathy Harrington, and please bear with me. I am the daughter of 2 residents that are there right now. World War II veteran, and my mom. And it was one of the most difficult decisions in our lives that they had to go into a nursing home. And the choices out there are not great. You know, I would have loved to say, yeah, Mom and Dad, stay home. We will get people to come in. It's not possible. You cannot get 24-hour care. People have to work. For whatever reason, Dad doesn't want to go to the veterans home. And I don't really want to move him. We've moved them before. So, you know, I've been through COVID in the nursing home. I've been through taking over as power of attorney. I've been through so much, and I cannot go through a crisis again. You cannot put me in a crisis again with my parents. I cannot go through it, I'm telling you. And I don't think you've had meetings with the families of the residents. And I would like to know why.
So one of the biggest challenges of any daughter is you don't get to be a daughter anymore. You have to become the caregiver. And I've seen it for 26 years. I'm in this industry because people need a voice. And the elderly have the best voice because they have the most to offer. They've been there and they've done that. And if we listen to them, we can learn an awful lot from them. So I look forward to learning a lot from your dad. I agree. You shouldn't. We're not going to try to put you through a crisis. So I look forward to meeting you in the building. We did have a few initially, and it goes back to the November snafu. We did come in, we did start having meetings, and then unfortunately we had the snafu and had to stop. So the plan would be once we're actually in, that we will start those meetings, and there would be a monthly meeting to talk about all of the things. And it could be it's soup to nuts. I mean, that's just an appropriate expectation. It's just about operations in general. And so I look forward to talking to you more and to meeting you in the building and going from there and meeting Mom and Dad, which I probably already have, but I want to make sure, yes. And also to our other neighbor, it'd be great maybe to get your contacts after so that when we're on board, we can do some chatting about a neighborhood ombudsman, that we could have those conversations. I know Dave has his stuff up there. I'll give you mine too.
I have another question about management. It says in here the Vermont location will be known as Mission Care at Bennington and will be operated by a new entity that is affiliated with the eye care network. So who is that new entity? Who's the management of it? Who is really going to be running the show? I mean, I hear you folks are going to be involved, but I think we would feel a lot better if we saw the leadership, if we heard them speak, and we knew something about, I love your philosophy. I'm on board with it. But when it gets to running the organization, it's who's got their feet in the facility all the time and is in charge. So what does this mean?
So a couple things. Yeah. So we are the leadership. I mean, that's Jess is the director of operations for Mission Care Health, which is not a different company. It's just a name that we use for this to distinguish this program. So Jess oversees the administrator who will run this program and the 2 other administrators that run Holyoke and 60 West. So we are the leadership, and they report up to us. So there's not you're not missing out on that. In terms of the new entity, that was actually added when I put this together because there was a concern when you saw the real estate is going to be owned by like Bennington Health and Trust or whatever. The real estate is an LLC. That's just the way you do it. So all of our nursing homes are like Bidwell Care Center doing business as, and it's just the name for the real estate. So there is no other company coming in. There's no separate organization. It's iCare, and we call these buildings Mission Care Health. And then the real estate is just its own. It's each company is an LLC, but there's no separate leadership or anything. It's just how we own the physical property. Does that answer satisfactorily? Yep.
Hi, Sarah Perrin. I live in Bennington. I had a question about some of the things you were mentioning about current population. If they decide they're not comfortable there, they've got questions, and they choose to transfer their care, and you're mentioning you're hoping to help them do that. What is the plan for that? How does that look? Is that monetary? Kind of just, can you give a little bit of how that might look?
Yeah, so I've talked to a couple families so far that reached out, I think based off of the Banner article and seeing my contact info, and certainly anybody can use this information for that purpose. But basically, what we said when we came into Holyoke was, I had a lot of families reach out. I talked to them directly. Some of them I talked to for hours or exchanged 30 emails or whatever to answer every one of their questions. And I said, you'll know when you know if you want your family member to move or to stay. It's not going to be something where if you don't have that knowledge now, that it's not going to become apparent to you. It's something that I encourage them to stay in touch with me and continue asking questions and get all of their concerns addressed. And if at the end of the day, they still didn't want to remain in that facility, then I would do everything I can to facilitate a transfer to whatever center they want them to go to in a managed way and not in a rushed way. In a, obviously with this senior population, you don't want drastic changes in their lives to happen in days. So it basically was explaining, don't feel like you have to make a decision today or tomorrow or next week. That option will always remain for these families to stay or to transfer. And if they decide they transfer, I will work with my team just to see who has open beds, where can you tour? We'll have conversations with Crescent Manor, and we've talked to, Southwestern Vermont in order to stay in touch with CLR, and we will help facilitate that, and then we will do it in a gradual fashion. Now, again, when we did Holyoke, we expected a mass exodus. We were like, all right, we're at 52. If we stay at 20 after this, we'll be shocked. Well, one left, and the rest of them stayed in place, and it was a lot of retired nuns. And they were living in it was Mount St. Vincent's, and they really felt that it was their new mission to care for this new population, and they all gravitated towards each other, and they've done really, really well together. Even to us, it's a little surprising. Like you would not intuitively think that, but one family moved out after we took over the operation. Now, if it happens that we have more that want to transfer, that might be the reality. I can't say that the same thing will happen here. The physical plant might be different, or the vibe may be different for them. We don't know that yet, but it's my commitment that it'll be as thoughtful a process as possibly can be if people want to transfer out. And of course, the other thing I'll just real quick is that there's a short-term rehab component there still, so there's probably a small amount, 10? We're down to 4 short-term rehab, so those 4 will discharge because they'll be through with their care.
Hi. My name is Annette Dudley. I live on North Terrace, and my comments are twofold. 20 years ago, I remember reading articles about our generation, the baby boomers, going to be huge, and that there wouldn't be enough healthcare workers, and we're there. There are not enough. I've had in the last year way too much experience in nursing homes. My good friend Michelle just passed away last summer in the Blackberry Lane facility. So I was there many times. It's an older building. I don't see how you're going to make that secure. Makes me very nervous. Thanks to Google, I've got maps. There's a little bit of woods behind that facility. Anybody that wants to could just climb up that hill, and if they are even more resourceful, there's Mutton Lane there that's paved. They can get up most of the hill and then go through a few pieces of woods, and they're in our backyard. Okay? So there's a lot of houses involved that are right within walking distance of this place. If anybody wanted to get out of there and had a mind to do it. Okay? Now, the future. Oh, I wanted to say, my experience in the nursing homes, people are overworked. There's not enough of them. Wonderful people I've had in that facility, and now my sister is at Hillcrest down in Pittsfield. People there are wonderful. They are understaffed. They are working their butts off. And they're terrific people, but they're understaffed. I cannot imagine how you're going to make this secure with people who are already overworked, and you're going to have trouble. And my husband's been doing a lot of research, and I know your Holyoke facility has had huge turnover with nurses leaving. I can't imagine why. I mean, I see the people in the 2 facilities I've been in, how overworked they are, and I can't imagine why they're still there. Now throw in that you got some former criminals or current criminals, I'd be leaving too, okay? So that's an issue. You got a lot of staff issues you're gonna have to worry about. But the future, I can't believe nobody else has even talked about this. There's gotta be people out there. This is a new concept. You've only got 3 facilities doing this. This is the 3rd. This is a new concept. Over the next few years, you're going to have criminals that are smart enough to start faking their symptoms, and they're going to work their way through the system. They got nothing better to do. They might be on a life sentence for something. What else do they have to do with their time than to sit down and figure out, how can I work my way through this system and get myself into a facility like this little town in Bennington that has a very tiny police force and has just a little piece of woods behind that I can just climb up a hill and I can be somewhere else.
Just to kind of address that. So I know it's kind of hard to picture if you aren't in these centers, but if you came to either of the 2 centers that do this and walked around, you'd be like, this is a nursing home. Like, it's a nursing home. The people that are there are not exit seeking. They're not looking, we're not doing something custodial. We're providing care to them. They're just not looking for the exit. It's just not how it works. And what happens is you have a visualization of who we're talking about, and it's not really who we're actually talking about. We're talking about a much sicker, much more infirm, much more debilitated. They don't have the faculties to put together something like trying to walk up a hill, or they're just looking forward to, I'm not joking when I say it, looking forward to bingo, looking forward to the next meal, looking forward to recreation and a book, watching TV in their room. I mean, it is not a corrections environment. It is a nursing home environment. And if I brought you to the ones we operate and didn't tell you what they were, you wouldn't even know. They look exactly like nursing home residents. They do not look like prisoners. They don't look like they're not young and able-bodied. They are nursing home residents. They just happen to have this stigma in their background. I get the concern. I know that I can say this again until I'm blue in the face. And when the program is 11 years old. I've been at iCare for just under 8. I came from an EMS background. It was my job, as my ambulance service would respond to the one in Connecticut. And I said, so are we doing shackles? Are we taking the corrections officers with us? And my former boss at iCare now, but back then was just somebody I knew, was like, that's not what we do here. Come and tour the place. And I went in and I said, oh, it's a nursing home. And he's like, yeah, no corrections, no. They're just not seeking exits. They're not physically able to do it. Every time I go in these buildings, I try to think of the mindset of, what if I didn't know what we do, and what would my thought process be? And I cannot find something that would trigger my concerns about it. It's just little old ladies and little old men shuffling in the hallways and going about their lives. And again, I know I can say it, and we'll have to be able to prove it. But that's what our experience has been.
Hi, I'm Jeannie Cody, and I'm a native Benningtonian. And so my question is, usually having grown up here, usually we're forgotten by Montpelier. So here we are, we're the flagship of Vermont for this new site. So I want to know how extensive the search process was to identify a location, because this is in a little tiny community.
So I could get into all the details of why we also think an existing nursing home is better than trying to build something or finding something empty. 60 West was completely empty and started from scratch. Mission Care was this model, in Holyoke rather, and Holyoke was a lot better of a run-up. We could get it started more readily. We had an active license. We had staff that was already there. We had a lot of things to work with. But when we did this in the state, and the Phase 1 contract allowed us to start searching for a facility, we hired a title company and we hired a third party like real estate agent, commercial real estate, to basically blanket the entire state, figure out every nursing home, see whether or not let's look at it geographically. We know it needs to be near population centers, needs to be near a hospital, needs to be accessible to folks, needs to be close to the referral sources, all of that. We know it's probably not going to be, high up in the northern part of the state, although we did look at one that was, in St. Albans, so we did consider that. But then it was down to which ones are the right size and which ones are actually going to be for sale. And so the window narrowed, and it narrowed to some that we were like, that geographically it's not going to work for us. It's not, the state, certain requirements the state had. And again, I don't love it, but Bennington was really pretty ideal. The size of the building was ideal. The fact that its occupancy level was where it was, the fact that the hospital was so close by, the fact that we could access Brattleboro and the retreat, for better or worse, we were extremely welcomed by everybody. I mean, everybody in Vermont has been very, very nice to us. So it was just, it worked out that way. And so we were down to 2 locations, and this is the one we really wanted. And when in November it looked like it was going to fall apart, we were like, this is bad, because we think this is going to be the best place for us to function, and run this operation. And so when it came back to be, we really pushed for it. When it came back on the table, we were happy about that, and it's obviously taken a little while to get to where we are, but that's how it worked.
Are there any other folks who would like to speak tonight? I just have a couple of closing comments. Within the last week, I've had several folks reach out to me. I had several doctors, and this is the capacity piece that you heard a number of the folks talk about tonight, that I've had doctors tell me right now, even after someone has a surgery in our hospital, they are not able to easily place them, if at all, to a nursing home for rehab for a couple of weeks or more. So taking this off kind of, as an alternative for folks to go to is very tough for this community. And I don't think anyone looked at that. I also had a family member of someone who presently is up there, and I'm very disappointed to hear tonight, because I was told a month or back in November, and then even when we talked 3 weeks ago, when I had to read in another northern paper that you were on deck again for this to happen, is that the care has gone down even further at the nursing home. This family member called me in Montpelier and said, "Can we talk?" She said, "We had to move our mother out." She said, "We never heard one word from you, and we were told back when that those discussions were had with the residents and their family, and everyone was staying." So I get concerned as we continue on, and I'm hearing a lot of different things tonight that is very different from when we met or talked before, or even when we had the meet or talked in November in the town office, when Stuart and others knew nothing about this. So that's very concerning to me, that these opportunities for our own people that have worked, lived here all their lives, will have to be placed somewhere else. And the person that called me that had to move her loved one out of the nursing home, and she said there's about 4 or 5 other families that are looking to do the same thing. She's not in Bennington County, she's in Rutland, and they were almost having to put their mother in New York State. That's not something we should be proud of, that we're pulling the rug out from under our own folks. So I'm very concerned with this. I hope, I think my head is spinning tonight of hearing all the different things. And I guess I would have to say, and I'm not saying this to put you on the spot, Commissioner, or interim commissioner, but I am concerned about another layer of another person having to learn about this. So our new commissioner, who will be on deck the 22nd of April, she's going to know nothing about what all of you talked about tonight, nothing. And quite honestly, David, when I asked you back, I think it was 4 weeks ago, about talking to the CEO, because I was getting a lot of lip service from you, and again, I know you're well-intended. You want it to be what you want it to look like, a real pretty picture, and I'm sure you do some great work, but you've got to prove it to us. But when I asked about talking to the CEO, your comment was, the discussion ends here. So if this is how open and transparent we're going to be, and we're going to have another layer of folks, I even hoped that the CEO or someone would be here tonight to say, we do care. We do care what's going on in Bennington. We want this to work, and that didn't happen. So I'm disappointed for these people.